Welcome to this video snippet on referred versus local pain. This subject isn't as clear-cut as you may think. Part of it is theoretical, but also part of it is practical. But I think we need to agree on terms a little bit here. So, interestingly, the International Association for the Study of Pain has not taken the trouble to define referred pain and local pain, nor differentiate between the two. I'm not sure why, but then their definition of pain is a bit iffy anyway. So maybe that's just one step too far for them. But given that they haven't defined this, we're free to do so, and so is everybody else. And I'll discuss some of the other ideas on this, but I'm going to give you basically mine, and this is what you'll probably find on impact. So we can say that referred pain, at the moment we can say this anyway, referred pain is that which is felt remotely from its cause. So local pain is that which is felt at its cause or very adjacent to it. Radiating pain, now this is interesting, is it the same as referred pain or not? We'll answer that in a minute. So there are a number of theories on how referred pain gets going. These date all the way back from 1880 or so, right up until current time. It's worthwhile mentioning straight off that none of these have been proven. So rather than these being theories, these are conjectures. Now, some of these have, well, all of them have some weakness, which is one reason that nobody's taking these as an absolute statement. Most of them, though, do match up with some of the experimental studies done. It's probably reasonable to suggest that some or all of these are involved in one way or another. Certainly, I think it's reasonable to think that central sensitization is a factor in this, because how long you have the pain does play a role in how much referred pain you get and how far it travels. But I'm not going to spend a lot of time on this. This is academic, and it really doesn't make too much difference to our treatments. Yeah, perhaps if they come up with a decent theory that is a true scientific theory, then we'll be able to treat this better. But right now, I'm not sure that it helps us an awful lot. So, quality of the pain, differentiating local pain and referred pain. First off, I want to get rid of neuropathic pain as a referred pain. If neuropathic pain is coming from damage to the central nervous or peripheral nervous system, and the pain seems to be traveling down that system, then it's local. The tissue that's causing the problem is involved in the sensation of pain. So it's arguable this is local. It's certainly a different quality of pain, it's a different source of pain, and I think certainly for the present discussion, we can take neuropathic pain out of this. Otherwise, we're looking at somatic pain. The pain tends to be an ache. Now, this isn't always true by any means. You can get sharp stabbing pain down the leg or in the arm, or coming from the viscera if the lining's involved. But more often than not, particularly with locomotor system problems, the pain is an ache, whereas local pain tends to be a sharper pain, although this can be an ache as well. So we're talking very much generalization here, but generally speaking, referred pain has an achy intensity to it, and it can be very severe ache at that, while local pain tends to be sharper, stabby, and so on. Does this help you in the diagnosis? Probably does a little bit. Certainly if I was seeing very sharp pain continuously going down the leg, it would make me question whether this is actually referred pain or something else, maybe an atypical neuropathic pain. So yes, I think it does help a little bit. Referred versus radiating. Now again, these terms are not well defined, but one definition I've seen of radiating pain is it's referred pain that is felt remotely from the source, but hasn't got a topographical association with the source. So you don't get this continuous band of pain going from say the lumbar spine all the way down the leg. The back may give you local pain, and then you find that they're aching in the foot or the knee or something. It does happen. It doesn't happen very often, but it does happen. The problem with that definition is you're using two terms for the same thing, both of them being referred pain. So let's see if we can change this a bit and make it more useful. If we say that referred pain is pain that travels or is felt in the dermatome or quasi-dermatome, remembering that some of these tissues have multiple innervations like the dura, so you can expect to see this as a bigger spread, but generally speaking it will go down the back of the leg or the front of the leg, down the side of the arm or whatever. So it tends to follow roughly dermatomes. Radiating pain we can define as pain that radiates away from the source. So we can say that referred pain isn't radiating from the source, it's being pushed down, which is very loose language, but it's being pushed down from the source, while as radiating pain is spreading from the source. One speculation I heard about why you get radiating pain is because of lateral recruitment of neurons in the cerebral cortex, the homunculus. So the intensity of the pain is so high that it just spreads in all directions. So you see somebody with a frozen shoulder, for example, this pain can be all over the bloody place. A fractured finger can basically hurt the whole finger or even the hand. So I think these are better definitions. One is telling you that the pain is obviously very intense, and if you get rid of the pain, the radiation will go away, and that may not be the same referred pain. And radiating pain may have nothing to do with central sensitization, because you fracture something and everything's paid for immediately. So I think this is a better use of the two terms. If we do that, then referred pain has two types. We have pain that is felt locally, and then topographically the pain travels from it down. It very rarely travels up the limb or from peripheral to central, but it travels down or around peripherally, away from the center. Very rarely does it come up. They're finding that it does come up with chronic pain syndrome patients, but not in otherwise healthy patients. So you can have referred pain that is topographically linked to the source, and you can have referred pain that isn't linked to the source. The latter is unusual, to say the least. So what potentiates referral? The intensity of the stimulus. The more painful this is, the more potential for intense pain and an extensive referral. The locality of the pain, and the more close it is to the spine, the more potential there is for referral also. It's unusual to see the wrist referring pain down into the fingers. If you fracture the wrist, you'll get pain all over the place, which is radiating pain. But to see it actually referring down a dermatome or two dermatomes down is unusual, very unusual. So the more central it is, the more referral you can expect, both in intensity and in distance traveled. How deep the stimulus, the deeper the tissue, the more potentiation there is for referral. So if you cut your skin, for example, the pain tends to be local, it tends not to refer, almost regardless of how bad that burn is. Again, if it's bad enough, it will radiate, but referring down the limb, it tends not to do that. And finally, the duration of the stimulus, how long the pain is present for, will also determine how far it travels and the intensity of that referred pain. Somatic pain, you tend to have more pain around the source than you do in referral, but that intensity can be made up for by the relentlessness of the ache. Also, don't forget that viscera are extremely central and very deep, so these have a great potential for referral out. Now, with the organs in trouble, you will get an ache with it. With the linings in trouble, this may be more musculoskeletal. Remember that everything we're talking about is a generalization. So issues. How far away from the source must the pain be to be considered to be referred? So if I've got a supraspinatus tendonitis, that is actually a tendonitis and extremely painful. So the pain is felt there, intense pain there. Over time, this thing can spread, around a bit that way. Or if you do overdo things with it, you can get this pain doing that as well. Now, how far does it have to spread before it's considered referred? Or it comes down over the deltoid in this area? At what point is that referred and at what point is that local? I don't think there's any standards on this. So it's both subjective for the patient and it's subjective for you. Remembering that the more referral there is, probably the more difficult this is going to be to get better because they've had it such a long time. Referred and radiating pain, I've talked about separating them out, but if the definition given in Wikipedia is the one you use, what practical difference does this make? None at all. So again, why use two terms when one term will do? And you've got better use for that radiating pain term. And again, is neuropathic pain local or referred? And I'll give you a view on that. I don't think they are, and I think they're different pains, and you can't equate the two anyway. So I hope this will be useful to you. Don't forget that pain is a symptom that you're dealing with 99% of the time. And it's right that you actually take trouble to talk to the patient about this pain for two reasons. One is you need to understand their pain, and the other one is they want to tell you about it. And if you cut them short, they're not going to be happy with you, and an unhappy patient is a complete misery for everybody. So take your time with this, take time to talk about the pain. It's the most important thing that you can really talk about with a patient. Okay, so I will talk to you on the Zoom session following this. And take care, everybody. Bye.